Welcome back to the deep dive. We take complex topics, really get into the source material, and pull out those key insights you need. Today, we're tackling a part of the body that causes, well, enormous trouble for so many people, the shoulder, and specifically the really intricate world of rotator cuff problems. We're going to explore everything from the basic mechanics right through to the most challenging revision surgeries. And importantly, what happens when things don't quite go to plan? Now, for this, we've been deep in some very detailed orthopedic texts. These sources lay bare the anatomy, the biomechanics, the surgical approaches, and sometimes the quite stark realities of managing complications. Our goal isn't to turn you into a shoulder surgeon overnight, obviously. It's more about giving you a really potent, synthesized understanding of this challenging area. Think of it as a shortcut to being genuinely well informed. We've structured this logically. We'll start with the sheer engineering marvel of the shoulder joint itself and the vital role of the rotator cuff. Then we'll look at what happens when the cuff fails and those initial steps taken to address it. After that, we'll delve into the surgical landscape. So everything from less invasive options to the deep complexities of revision procedures and those common complications that can crop up. And finally, we'll touch on how technology is shaping things and look at outcomes in some specific patient groups. And I'm delighted to be joined today by Prof. Mo Imam. His expertise allows us to really cut through the density of this material to synthesize this complex medical information and provide that crucial context. You needed to understand the intricate decision making and the often variable outcomes we see discussed in these texts. Prof. Imam, it's excellent to have you with us.
Thank you. It's a pleasure to be here. The shoulder really is fascinating, but inherently complex. That huge range of motion, it does come at a cost. It makes it quite susceptible to injury. And as these sources clearly show, repairing and managing those injuries, especially when they're recurrent or perhaps combined with arthritis, well, it presents significant challenges. Getting to grips with the biomechanics is absolutely the essential starting point.
Okay, let's unpack that foundation then. You mentioned the biomechanics. What exactly is the rotator cuff and what's its key role in this, well, incredible piece of biological engineering?
Right. Well, the rotator cuff is a critical functional unit. It's made up of four muscles and their tendons, and these surround the glenohumeral joint. That's the main ball and socket part of the shoulder, where the humerus, the arm bone, meets the scapula, the shoulder blade. The muscles are the supraspinatus, infraspinatus, teres minor, and the subscapularis.
So four distinct muscles, each attaching to the humerus via a tendon. And their role isn't just about moving the arm then.
Precisely. While they are definitely responsible for rotation and they contribute to lifting the arm, their most crucial function, really, is providing dynamic stability to that ball and socket joint. They achieve this by working together in a coordinated way. It's often described as a force couple.
A force couple, right. Can you elaborate on that a bit? What does that actually mean in the context of the shoulder?
Okay, think of it like a finely tuned engine. You've got the supraspinatus sitting on top, the infraspinatus and teres minor are on the back, and the subscapularis is right there on the front. When they contract together, they generate opposing forces, but crucially, they're balanced forces. And this coordinated pull, it acts to keep the head of the humerus, the ball part, centered directly within that shallow glenoid fossa, which is the socket.
Ah, okay. And that centering, that's the key to stability.
Absolutely vital. It's the principle of concavity compression. You see, the glenoid, the socket, it's really quite a shallow dish. It's not a deep cup like the hip socket. So the rotator cuff muscles apply this compressive force. They essentially push the humeral head firmly into that shallow concavity. And this compression increases the stability of the joint throughout its entire range of motion, especially during powerful movements. Without that focused compression, the humeral head would just be prone to sliding or translating excessively on the glenoid surface.
Right. So it's not just the static things like ligaments and the joint capsule holding it together. It's this active muscular squeezing that keeps the ball centered, that dynamic stability you mentioned.
Exactly. And it's the really sophisticated interplay between those passive static restraints and the active dynamic force of the rotator cuff that grants the shoulder its remarkable range of motion, while ideally maintaining that crucial stability.
You mentioned the four muscles. Do they all play equal roles, or is one perhaps more significant than the others?
Well, they're all essential for that force couple to work properly. But the sources do highlight the subscapularis as the largest and most powerful of the four. It originates from that broad anterior surface of the scapula, the front of the shoulder blade, and it has a really substantial insertion onto the humerus. This insertion is actually quite interesting. It's made up of two distinct parts, a more tendinous upper part and a more muscular lower part. And that tendinous portion, it's notably broader. It covers about 2/3 of its attachment footprint. And the superficial layer of that tendon is thicker too. This muscle is the primary internal rotator of the arm, and it's absolutely crucial for anterior stability and contributing to that anterior compression of the joint.
Okay, so the subscapularis is a major player, particularly for turning the arm inwards and stability at the front. What about the others? We often hear about the supraspinatus being injured.
Yes. The supraspinatus is probably the most commonly injured. Its anatomy is generally quite consistent. It sits on top of the joint. Though you do see variations in its exact attachment points sometimes. It can extend to structures like the lesser tuberosity, or even bits of the pectoralis major or the superior transverse scapular ligament. Its primary job is initiating the lifting of the arm out to the side. That's abduction, especially in the very early degrees of movement. Then you have the infraspinatus and teres minor. They sit on the posterior aspect, the back of the shoulder. They're the main external rotators, so key for posterior stability.
So if this coordinated force couple and concavity compression are so fundamental to keeping the humeral head stable, what happens when a tear disrupts that delicate balance? What are the immediate consequences?
Well, a tear, or any significant damage that compromises the integrity or function of one or more of these muscles, it directly disrupts that force couple. It's immediate. The ability to generate that necessary compressive load is diminished. And this straight away alters the forces acting across the joint. The torques, the joint reaction forces, they're no longer balanced, and stability is compromised.
And the sources point to a specific common outcome of that instability, don't they? Superior humeral head migration.
Absolutely. This is a classic consequence, especially when you have larger tears involving the superior part of the cuff, like the supraspinatus. You see, without the counteracting downward pull and compression from the torn superior tendon, the powerful deltoid muscle, that big muscle sitting over the shoulder that lifts the arm, it no longer has its opposing force. So the deltoid's unbalanced pull drives the humeral head upwards, superiorly, within the glenoid fossa.
And that upward movement causes pain because it's essentially hitting structures above it.
Precisely. That superior displacement causes the humeral head to impinge or, well, crash into the underside of the acromion, which is the bony roof of the shoulder.
Yeah.
And this is the source of that painful subacromial impingement.
Yeah.
It also severely restricts the range of motion, particularly lifting overhead.
You mentioned the supraspinatus initiates abduction. How does that work with the deltoid, and how does a tear affect that mechanism?
Right, so during abduction, lifting the arm out at the side, the supraspinatus is the primary muscle generating the initial lift, especially at those low angles, sort of the first 15-30 degrees. As the arm moves higher, the deltoid muscle becomes increasingly dominant. It provides the necessary torque for elevation. However, maintaining that intact force couple, that balanced action of all the rotator cuff muscles counteracting the deltoid's upward pull, that's absolutely essential to keep the humeral head centered throughout that entire arc of motion. Now, if there's a large tear in the supraspinatus, the remaining muscles of the force couple and the deltoid itself, they have to work much, much harder to try and maintain some semblance of stability and actually achieve elevation. And this increased load on the remaining cuff tissues, well, unfortunately, that can lead to the tear propagating. It can extend forwards into the subscapularis or backwards into the infraspinatus and teres minor.
So one tear can put excessive strain on the others, potentially leading to a kind of domino effect of failure.
It's a real risk, yes. A definite possibility. And just quickly, the sources also mention the suprascapular nerve, which is relevant here. It's a nerve that originates from the neck, passes under the transverse scapular ligament, and provides motor control to both the supraspinatus and infraspinatus muscles. It also has sensory branches to key ligaments and the joint itself. So injury or irritation to this nerve, maybe from the original trauma or potentially even during surgery, could actually contribute to ongoing pain even after a repair attempt.
That highlights another layer of complexity, doesn't it? So, okay, we understand the anatomy, the elegant biomechanics, and the immediate cascade of problems when a tear occurs. What's the typical first approach when someone presents with a rotator cuff issue? Is surgery always the immediate answer?
Not at all. No. The literature strongly supports starting with a trial of non-operative management in almost all cases. And the cornerstone of this is physical therapy. The focus is initially on restoring any lost range of motion, which might be limited by pain or stiffness. And then, crucially, strengthening not just the remaining functional parts of the rotator cuff, but the entire shoulder girdle and the muscles around the shoulder blade, what we call the parascapular musculature.
So essentially trying to compensate and improve stability using the muscles that are still working effectively.
Exactly. Optimizing the overall mechanics and the muscle recruitment patterns. trying to improve dynamic stability and function with the capacity that remains.
And if that conservative approach isn't successful, when does surgery actually come into the picture?
Well, surgery is generally considered when non-operative management fails to provide adequate symptom relief and restore satisfactory function for the patient. But the decision is highly individualized. It really takes into account several factors. There's the patient's age, their overall health status, any comorbidities they might have, also their functional demands and expectations for recovery, and critically, the size and pattern of the initial tear, as well as the quality and condition of the remaining rotator cuff tissue. Things like muscle degeneration or fatty infiltration within the muscle, those are really important considerations.
So it's not just about the hole in the tendon itself, but the state of the surrounding structures and the patient's overall health profile.
Precisely. The success of any repair is heavily dependent on the quality of the tissue you're working with and the biological environment for healing.
Are there situations where the sources suggest surgery is more urgent or immediately indicated?
Yes, there's a specific scenario highlighted that's an acute traumatic re-tear in a young patient who has previously had a successful repair. So if a young, active individual suffers a new injury that tears a repaired cuff acutely, the recommendation is often for relatively prompt revision surgery. The rationale there is that the tissue quality and the healing potential are generally thought to be better in an acute setting compared to a chronic, long-standing re-tear.
That makes sense clinically, getting to it before tissue retraction and degeneration potentially worsen the situation. When assessing these patients, what's involved in the initial physical examination?
A thorough patient history is absolutely paramount. You need to understand the nature of their symptoms, the duration, any prior treatments, and crucially, what functional limitations they're actually experiencing. What can't they do that they want to do? The physical examination then complements this. We assess both active and passive range of motion. That helps distinguish limitations caused by stiffness from those caused by weakness. And crucially, we perform specific physical tests. These are designed to evaluate the function and integrity of each individual rotator cuff muscle.
Could you give us a few examples of those specific tests? What are you looking for?
Certainly. So for the supraspinatus, common tests include the starter test and the Job test, sometimes called the empty can test. To assess the infraspinatus, we test external rotation strength and look for something called an external rotation lag sign, where they can't hold the arm rotated outwards. The function of the teres minor is evaluated with the hornblower test. And for the scapularis, we use tests like the liftoff test, the belly press test, and we specifically measure internal rotation strength, often with a handheld device.
So systematically assessing each component of that critical force couple we talked about earlier.
Exactly. And alongside that, a detailed neurovascular examination is vital. We need to check the major nerves supplying the shoulder and arm, like the axillary, radial, and thoracodorsal nerves. Nerve function can impact strength and pain, obviously. So assessing this is crucial for accurate diagnosis and, of course, for surgical planning.
Right, gathering all that information to determine the best path forward. So we start with non-operative treatment, and if that fails, we consider surgery based on a really nuanced assessment. But what happens in those challenging scenarios, when the tear is just too large or the tissue quality is too poor to repair, or when a previous surgery hasn't been successful? Let's move into the surgical landscape, particularly for these complex cases. What's the role of something like arthroscopic debridement when a tear is deemed irreparable?
Right. Arthroscopic debridement in the context of irreparable rotator cuff tears, it's primarily considered a palliative procedure. What that means is its main goal is to relieve symptoms, particularly pain, rather than achieving a successful biological repair of the tendon back to the bone. It's often used in revision settings or when the tissue quality is simply too poor to even attempt a re-repair.
Palliative because you can't actually sew it back together, but you can sort of tidy things up inside the joint.
Precisely. That's a good way to put it. It's done arthroscopically, using a small camera and instruments through keyhole incisions. The surgeon will remove any significant bone spurs or osteophytes that are usually found on the undersurface of the acromion or perhaps on the humeral head. This needs care, obviously, to avoid nearby nerves like the axillary nerve. They'll also remove any unstable or damaged cartilage flaps on the joint surfaces and perform a bracectomy that's removing the inflamed subacromial bursa, that lubricating sac. The aim is really to eliminate sources of mechanical impingement or irritation within the joint space.
And what does the evidence tell us about the effectiveness of just debridement? Even if it's not fixing the tear itself, can it still provide genuine help for patients?
Well, the sources point to several studies showing that debridement, despite not repairing the cuff defect, can provide meaningful symptomatic relief for a significant portion of patients. Studies by Pander and Park, for instance, they reported notable improvements in subjective pain scores, function, and patient satisfaction. And these results sometimes held up for several years. Franceschi and colleagues even showed that outcomes after debridement were comparable to those seen after partial repairs in terms of improvement. And interestingly, debridement actually yielded gains in range of motion, like forward flexion, in their study. Shu and colleagues found that a high percentage, about 73% of patients undergoing a similar procedure, achieved what's called a minimal clinically important difference, or MCID, in their outcomes. And Klinger et al. Further suggested similar improvements, whether debridement was performed alone or combined with addressing the biceps tendon, like a tenotomy.
So the key takeaway here seems to be that for these really difficult, irreparable tears where a full repair just isn't feasible, simply cleaning up the joint space and removing the irritants can provide significant pain relief and functional improvement for many people. That offers a less invasive option when faced with quite limited surgical choices.
It absolutely does. It's a pragmatic option. It's focused on improving quality of life when biological repair is unlikely or, frankly, impossible.
Beyond simply tidying up, there's a lot of research into actively trying to improve the biological environment for healing, isn't there? This is where biologic augmentation comes in.
Yes, that's right. The concept is essentially to introduce biological materials or cells to enhance the body's natural healing response at the repair site, particularly after rotator cuff surgery. Platelet-rich plasma, or PRP, is probably the most discussed example. It gets a lot of attention.
Yes, PRP injections have certainly gained a lot of public profile. What does the basic science suggest it might actually do for tendon healing?
Well, in vitro studies, studies looking at cells in a lab dish, they have shown that exposing tenocytes, those are the cells that make up tendons, to PRP can stimulate them to multiply. And it can increase their production of matrix materials, which are the essential components of tendon tissue. PRP has also been shown to potentially encourage tendon stem cells to mature into active tenocyte-like cells capable of producing collagen.
Okay, that sounds quite promising on a cellular level. But translating that promise from the lab to real-world clinical healing must have its complexities.
Oh, absolutely. And the sources really highlight a major challenge with PRP. It's immense variability. You see, the exact composition of any PRP product, meaning what growth factors and cells are actually present, is highly variable. It's influenced by numerous factors specific to the patient themselves, things like their age, sex, diet, even their activity level. And crucially, it's also heavily dependent on the method used to prepare the PRP from the patient's own blood. Things like the type of blood collection tube used, the centrifugation speed, the number of centrifugation cycles, all these dramatically affect the final product.
So the PRP from one person might be quite different from another, and even from the same person on a different day, or if it's just prepared slightly differently in the lab.
Precisely. This huge variability in preparation protocols and individual patient factors makes it incredibly difficult to compare results across different studies. And to generalize findings, whether that's from laboratory research or clinical trials, looking at healing rates or patient outcomes. This variability is a key reason why the clinical results with PRP and rotator cuff repair have been, well, somewhat inconsistent, frankly.
Are there other, perhaps less well-known potential sources of biological augmentation being explored?
Yes. The sources do mention the potential use of subacromial bursa-derived cells, or SBDCs. Now, the subacromial bursa, as we mentioned, is that layer of tissue between the rotator cuff and the acromion. It's often removed during shoulder surgery, particularly for decompression or just to improve surgical access. But recent research suggests that this bursal tissue actually contains mesenchymal stem cells, or MSCs.
And MSCs are interesting because they have that potential to differentiate into various tissue types, including those relevant to tendons and connective tissue repair.
Exactly. And the sources note that the collagen making up new healing tissue at a tear site appears to originate from loose connective tissue sources, like the peritoneum, which is tissue surrounding the tendon. So exploring the use of these MSCs from the subacromial bursa, which is easily accessible during surgery and would otherwise just be discarded, it represents a potentially inexpensive and viable source for augmenting rotator cuff repair healing. It's definitely an area of ongoing research interest.
Okay, moving from rotator cuff tears to the joint surface itself now. What about patients, particularly younger and more active ones who develop arthritis in the shoulder? The sources discuss strategies for joint preservation and also when replacement surgery, arthroplasty, might be necessary, especially given the challenges of putting traditional implants into younger, more demanding individuals.
Yes, this is indeed a significant challenge in orthopedics. Traditional total shoulder arthroplasty, or TSA, where both the ball and socket surfaces are replaced with implants, has historically shown lower longevity and less predictable outcomes in younger, highly active patients compared to older or less functionally demanding groups. Some studies have reported failure rates, meaning needing further surgery, as high as 62.5% within 10 years in this younger population.
Wow, that's a very high rate of needing more surgery. So, what are the potential initial approaches or alternatives for a younger patient with joint surface wear or arthritis? Are there options before jumping to a full replacement?
Yes, one approach discussed in the sources is comprehensive arthroscopic management, known as CAM. This is a joint-preserving procedure. It's performed arthroscopically, so keyhole surgery, and it's specifically tailored for younger, active patients who have symptomatic osteoarthritis, either advanced or perhaps less severe disease that's still causing problems.
What makes CAM comprehensive compared to the simple debridement we talked about earlier? What else does it involve?
Right, it goes well beyond just simple debridement. SAM includes the standard arthroscopic procedures like removing loose bodies, synovectomy that's cleaning out the inflamed joint lining, subacromial decompression, removing bone spurs under the acromion, chondroplasty, tidying up rough cartilage edges, and potentially microfractures for small cartilage defects on the bone surface. But it also includes more extensive procedures, things like an extensive capsular release to address joint stiffness, management of the biceps tendon, either cutting it, a tenotomy, or reattaching it elsewhere, a tenodesis, and humeral osteoplasty, which involves carefully reshaping the humeral head by removing prominent bone spurs, sometimes colloquially called the goat's beard. A unique component mentioned in the sources for CAM is the potential for decompression of the axillary nerve if it appears compressed or at risk.
So it's a real multifaceted arthroscopic procedure tackling multiple potential sources of pain and mechanical problems in that arthritic joint. What are the outcomes looking like for CAM? Does it work?
While studies like the one by Arner and colleagues, reporting on 10-year outcomes, show that CAM can be effective. It can provide significant pain relief and improve function for carefully selected patients. The aim is often to provide symptom relief and potentially delay the need for a full joint replacement surgery. Rehabilitation after CAM is absolutely crucial. It focuses on early regaining of range of motion, followed by strengthening. Most patients reach their maximum recovery by about 4 to 6 months. It's generally viewed as a sort of bridge procedure, buying valuable time for a younger patient before needing a replacement.
Another joint preserving option mentioned, particularly for younger patients with arthritis mainly affecting the ball side of the joint, is humeral head resurfacing, or HHR. How does that differ from a traditional TSA?
HHR involves placing a metal cap, essentially like a crown you'd put on a tooth, onto the surface of the humeral head itself. This is instead of replacing the entire head and inserting a stem down the bone canal, as you do in a traditional TSA. It's an option considered for large, full-thickness cartilage defects or more widespread lesions affecting the surface of the humeral head.
What are the specific advantages of HHR, particularly thinking about a younger patient?
Well, a primary advantage is bone stock preservation. You're not sacrificing the natural humeral head or inserting a stem into the bone canal. You preserve the neck of the humerus and usually more than 50% of the humeral head itself. And crucially, it aims to preserve the patient's native anatomy, things like the angle between the neck and the shaft of the humerus, the version, which is the natural twist, the inclination, and the original center of rotation and offset of the joint.
And preserving that natural anatomy sounds like it could make things easier down the line if perhaps further surgery is ever needed.
That's the major theoretical benefit, yes. By not significantly altering the native bone structure and alignment, if the HHR eventually wears out or fails for some reason, subsequent revision surgery might be simpler. It could potentially allow for the use of a more conventional stem-based humeral component later on.
What does the evidence actually say about the outcomes of HHR? Is it effective?
Studies suggest HHR can be effective for pain relief, improving range of motion, and achieving good patient satisfaction, particularly in patients whose arthritis is caused by osteonecrosis. That's a loss of blood supply leading to bone death in the humeral head. Some literature even suggests outcomes comparable to TSA for this specific condition. However, patients must be counseled. They must be aware that the native cartilage on the glenoid, the socket side, will continue to experience wear over time. And this can eventually lead to recurrence of symptoms and the potential need for future revision surgery.
So it fixes the ball side, but the socket is still potentially vulnerable to wear and tear.
Exactly. And importantly, studies, such as those by Hatrup and Feely cited in the sources, they highlight that outcomes are generally inferior for osteonecrosis that results from trauma compared to primary vascular necrosis where there was no preceding injury. Trauma-related bone death seems to be a tougher challenge for HHR to address successfully.
Managing the glenoid side, the socket, sounds equally important then, especially in patients with osteoarthritis where bone loss or deformity can occur. How do surgeons address defects on the glenoid side?
Addressing glenoid defects is absolutely crucial for the success and longevity of any shoulder arthroplasty, whether it's a resurfacing or a full replacement. For smaller defects, typically less than 10-15 degrees of malalignment or version change, surgeons might use asymmetric reaming. This involves selectively grinding down one side of the glenoid surface to try and flatten it or reorient the socket. However, this can compromise the patient's own bone stock if done too aggressively.
And what about more significant bone loss on the socket side?
For more pronounced defects, bone grafting is often employed. This involves adding bone to reconstruct the deficient area. Techniques include using structural cortical grafts, which are solid pieces of bone, impaction grafting, where bone chips are packed tightly into the defect, or using either the patient's own bone, an autograft perhaps taken from the humeral head that's removed, or donor bone, an allograft. Studies like the one by Italia and colleagues demonstrate the ability of these techniques to restore anatomy and bone stock. And Jones et al. Found high rates of graft incorporation, noting no significant difference in results between using autograft or allograft bone.
And for really severe glenoid bone loss, there's an even more complex technique mentioned, osteochondral allograft transplantation. That sounds quite involved.
Yes, this is a specialized option, usually reserved for severe glenoid bone loss, often exceeding 20% of the socket surface area. It involves transplanting a block of bone and cartilage from a donor source to reconstruct the glenoid. The goal here is to restore the normal joint surface with living articular cartilage, which provides a smooth surface for the humeral head to articulate against. And it helps restore joint congruity and stability, aiming to prevent or delay further degeneration.
That definitely sounds technically demanding. What have the outcomes been like for that procedure?
Well, a systematic review by Vega and Mirzayan and case reports like the one by Camp et al. Highlight quite promising clinical outcomes. They report reduced instability, high graft incorporation rates with minimal resorption, and significant pain relief and patient satisfaction. It does require detailed 3D CT imaging preoperatively to meticulously plan the size and shape of the graft needed. However, the sources do note the need for more long-term outcome data to fully establish its widespread role and durability.
Is there also an arthroscopic option for managing the glenoid surface itself, perhaps less invasively?
Yes, arthroscopic glenoid resurfacing, or AGR, is mentioned. This often involves using a soft tissue graft, like a dermal allograft processed donor skin tissue, to cover the worn or damaged glenoid surface. It's described as a safe, joint-preserving option for carefully selected patients with moderate, say grade 2 or 3 on the Samuelson and Prieto classification, osteoarthritis on the glenoid side.
So essentially putting a new soft tissue layer over the worn socket surface arthroscopically.
That's the principle, yes. Studies suggest it can provide worthwhile pain relief and improve function for these selected patients. Now, while revision rates to prosthetic arthroplasty are considered acceptable as short to midterm follow-up, studies by Hartzler, Savoy, and De Beer did identify factors like increased patient age and lower preoperative function scores as risk factors for the procedure failing and eventually requiring conversion to a full arthroplasty. It's considered a technically demanding procedure, best performed by experienced surgeons, and it's generally viewed as another potential bridge to future arthroplasty, perhaps delaying the need for implants for a number of years. A key benefit, though, is avoiding the potential loosening issues associated with the polyethylene glenoid component used in traditional TSA.
Okay, so we've covered the non-surgical start, palliative debridement, biological augmentation, and these various joint-preserving techniques for arthritis. Now, let's move into the even more complex world of revision surgery. Going back in when a previous procedure, whether that was a cuff repair or a joint replacement, hasn't worked out as intended. What are the considerations when undertaking revision rotator cuff surgery?
Right. Revision rotator cuff surgery, re-repairing a tendon that has failed after a previous attempt, is indeed more complex than a primary repair. The indications are similar in principle. You're addressing pain and loss of function that haven't responded to non-operative measures. But managing patient expectations is absolutely paramount in this situation. The outcomes are generally less predictable than primary repairs. The sources reinforce that an acute traumatic re-tear in a biologically young patient is a strong indication for revision, as we discussed earlier, due to potentially better tissue and healing.
And for chronic re-tears, where it's perhaps happened gradually or been present for quite a while.
For chronic re-tears, Much like primary tears, the initial approach should generally be a trial of non-operative treatment, focusing again on regaining range of motion and strengthening what's left. Surgery is considered if that conservative management is unsuccessful, again factoring in the patient's age, demands, and critically, the quality of the remaining tissue. Is there enough viable tendon to actually work with?
How do you actually diagnose that a re-tear has occurred after a previous surgery? What are you looking for?
Post-operative imaging is essential. The sources advocate for a multimodality approach, using a combination of standard X-rays, ultrasound, perhaps CT arthrogram, and definitely MRI. These studies help confirm if a re-tear is present, determine its size, and importantly, its location and the degree of retraction, how far the tendon has pulled back. The sources mention specific classifications for re-tear location, such as type 1 lesions where the tendon pulls away right from the bone edge, and type 2 lesions where the tear is actually through the tendon tissue itself, away from the original repair site on the bone. The PAT classification is used to measure the amount of tendon retraction seen on coronal MRI views. It is noted in the literature, though, that the reliability among different observers in describing the precise location of re-tears can sometimes vary.
So imaging confirms the problem exists. When planning a revision repair, what are the key biomechanical principles highlighted in the sources for trying to achieve a more robust fixation this time around?
Well, understanding the potential biomechanical reasons for the initial failure is key. The sources delve into optimizing suture anchor placement and how the sutures are passed through the tendon and anchored to the bone. They discuss the dead man theory for suture anchor insertion. Biomechanical studies suggest this provides the strongest fixation when the angle of the suture passing through the tendon relative to the bone surface, and ideally the angle of the suture relative to the anchor itself, are both 45 degrees or less. There's generally good consensus on that 45-degree angle for the suture. Through the tendon, it maximizes compression at the footprint. There's perhaps less controversy or strong evidence regarding the optimal angle relative to the anchor itself.
Interesting how those specific angles really matter for strength. Are there any newer techniques mentioned that aim to improve the biomechanics and potentially reduce the risk of these re-tears happening again?
Yes, the sources briefly touch upon some evolving techniques. Things like TOE repairs, which stands for transosseous equivalent repairs, and even techniques like leaving the medial row sutures untied in certain double row constructs. These are being explored as potential strategies to minimize the risk of those things. Top 2 re-tears, the ones tearing through the tendon substance itself, which can be particularly difficult. However, the sources rightly note that these techniques require further study to definitively confirm their clinical benefits in preventing re-tear compared to established methods. It really underscores the ongoing search for biomechanically superior repair constructs, especially in the revision setting.
Okay, moving now from cuff repairs to joint replacements. The sources highlight quite starkly that complication rates are significantly higher in revision shoulder arthroplasty compared to primary surgery.
They absolutely do, and this is a critical point for both surgeons and patients to understand and discuss beforehand. While primary total or reverse shoulder arthroplasty has a relatively low overall complication rate, revision surgery presents a much more challenging landscape. Infection rates, for example, can be substantially higher in revision cases, sometimes reported up to 15.4%. And overall complication rates have been reported as high as 68% in some difficult revision series. You see, previous surgery inevitably alters the anatomy, the tissue quality, the scar tissue planes. It just makes subsequent interventions inherently more difficult and riskier.
One of the most dreaded complications must be periprosthetic joint infection, or PJI. What are the warning signs a patient might experience if the replacement becomes infected, and how is it typically diagnosed?
Yes, PJI is a very serious complication. The most common symptom is persistent and often severe pain. Pain that's typically worse than expected after surgery and doesn't seem to improve with time, or might even worsen. Other signs to look out for include a draining sinus tract from the surgical site, unexplained stiffness, warmth, redness, or swelling around the joint. Less common signs might include systemic symptoms like fever or chills, but often they're absent in chronic shoulder PJI.
And the diagnostic process, how do you confirm it?
Diagnosis requires a comprehensive approach. High-quality radiographs are an essential first step. You're looking for telltale signs like radiolucent lines. Those are visible gaps on the X-rays between the implant components and the surrounding bone. Also looking for bone erosion, osteolysis, which is bone breakdown, scalloping of the bone, or signs that the components might have shifted or migrated. The sources specifically link humeral loosening and osteolysis around the humeral stem to an increased risk of Cutibacterium acnes, or C. acnes, infection. This is a common, slow-growing bacterium that's often implicated in shoulder PJI. Lab tests, like C-reactive protein, CRP, and perhaps procalcitonin, are helpful inflammatory markers, although the predictive value can vary based on the specific values obtained and the patient's individual risk factors.
Is taking a sample of the fluid from inside the joint part of the standard diagnosis?
Yes, joint aspiration is a key diagnostic step. A high white blood cell count in the aspirated fluid is strongly suggestive of infection. Now, while a threshold of over 20,000 cells per microliter is often used for diagnosing infection in native joints, the threshold is typically lower when an implant is present, as implants themselves can cause a slight inflammatory reaction. It's also important to remember that conditions like immunosuppression can affect these cell counts, making diagnosis trickier. Alpha-defensin is another marker that's been studied in joint fluid, but its sensitivity for diagnosing shoulder PJI appears to be more variable compared to its established use in hip or knee infections. The sources suggest that obtaining arthroscopic tissue biopsies for culture may actually offer improved diagnostic accuracy compared to aspiration alone. It allows direct sampling of the tissue right around the implant.
How is periprosthetic joint infection typically treated? Is it usually a single surgery to fix it?
Treatment involves a combination of surgical intervention and prolonged antibiotics, often for many weeks or months. The main surgical debate revolves around a one-stage versus a two-stage revision approach. Two-stage revision has traditionally been the standard, largely borrowed from extensive experience with hip and knee replacements. This involves a first surgery to remove all the infected components, perform extensive debridement that's meticulously cleaning out all the infected and non-viable tissue, and typically implanting an antibiotic-impregnated cement spacer to maintain space and deliver local antibiotics. The patient then receives a course of intravenous antibiotics, usually for several weeks, before a second surgery is performed to implant the new prosthesis components, assuming the infection has been successfully eradicated.
And the one-stage approach, how does that differ?
A one-stage revision involves removing the infecting components and performing that same thorough debridement, but then immediately implanting the new prosthesis components in the same surgical sitting, followed by the prolonged course of antibiotics. The sources note increasing interest in single-stage revision for the shoulder. The rationale is that it involves less overall soft tissue insult compared to two major surgeries. It potentially allows for faster patient recovery, and it can be more cost-effective for the healthcare system. A systematic review mentioned in the literature even suggested lower reinfection and complication rates with single-stage procedures, though the authors rightly caution that this finding might be influenced by selection bias, meaning perhaps less complex or less virulent infections might be preferentially chosen for single-stage revision.
So careful patient selection is absolutely key if you're considering the one-stage approach.
Absolutely. Meticulous patient selection and a really rigorous, thorough debridement are paramount for achieving success with single-stage revision PJI treatment.
What happens if the infection is particularly stubborn and just can't be cleared even with these revision surgeries? Are there any options left?
Yes, in difficult cases of recalcitrant PJI, that's infection that persists despite repeated treatment attempts, or perhaps for patients who are very low demand or medically frail, a salvage option is resection arthroplasty. This involves removing the prosthesis components and all the infected tissue, but not implanting a new joint. You essentially leave the joint space empty, allowing the soft tissues to scar in.
What are the outcomes like for resection arthroplasty? Does it work?
Well, it can be very effective at eradicating the infection itself, achieving high infection resolution rates. However, the functional outcomes are often quite poor. Patients frequently experience significant residual pain and severely limited function, reported in up to 50% of cases in some studies. Resection also leads to significant muscle atrophy and further bone loss over time, which can severely compromise or even make impossible any future attempt to implant a new prosthesis if circumstances change. It's a really difficult compromise, often a last resort.
And what about the situation where bacteria are found during a revision surgery that wasn't initially suspected to be infected? This concept of unexpected positive cultures, or UPCs, how is that handled?
Yes, UPCs. The sources highlight that there is currently little consensus in the orthopedic community on the best way to manage unexpected positive cultures found during revision surgery that was planned for reasons other than infection, like loosening or instability. More research is definitely needed in this area to establish clear guidelines. One study discussed treated patients undergoing single-stage revision who had two or more unexpected positive cultures, often for that C. acnes bug we mentioned, with postoperative antibiotics. They reported comparable functional outcomes to a control group without such cultures, but the definition of the control group had some limitations. Another study found that almost a quarter, 23.9% of revision surgeries performed for reasons other than known infection still yielded at least one unexpected positive culture, and these were often treated empirically with oral antibiotics post-operatively based on surgeon judgment. This area really requires clearer protocols based on further evidence.
Infection is clearly a major hurdle. Beyond that, instability, that feeling that the joint is loose or going to dislocate, is another significant complication after arthroplasty.
Instability is indeed a significant problem after shoulder replacement, and it can be very disabling for patients. The sources strongly emphasize that prevention is the best strategy here, beginning with careful preoperative assessment. This involves using advanced imaging like CT scans to properly evaluate the patient's underlying bone stock, and particularly the version or natural twist of the glenoid socket, as well as MRI to assess the rotator cuff muscles for any tears or fatty infiltration that might compromise stability.
And during the surgery itself, what factors are critical for preventing instability?
Intraoperative factors, particularly proper component positioning, are absolutely vital, especially for anatomic TSA. The humeral component, the ball side, must be placed in the correct version, replicating the patient's natural anatomy as closely as possible and at the correct height. Placing it too proud or high can lead to impingement against the acromion or glenoid rim, while allowing it to subside into the bone can compromise that essential concavity compression effect we discussed earlier, leading to instability.
And for reverse total shoulder arthroplasty, RTSA, where the mechanics are different, what influences stability there?
Right. RTSA mechanics rely much more heavily on adequate tension in the deltoid muscle and any remaining functional rotator cuff tissue. Lateralizing the components, which means shifting the overall center of rotation outwards, away from the scapula, helps increase deltoid tension and generally improve stability. The position of the center of rotation, COR itself, is also crucial. A more medial COR, closer to the scapula, can potentially create a dislocating lever arm effect in some situations, whereas designs that lateralize the COR are generally preferred from a stability standpoint. The sources also note that the depth of the humeral socket component, the cup on the arm side in an RTSA, seems to have a greater influence on overall stability than the actual size of the glenosphere, the ball on the glenoid side. However, there's always a trade-off with constraint. Using more constrained components provides greater inherent stability, but increases the risk of implant impingement during movement, and it can reduce the overall range of motion achieved.
If instability does occur after arthroplasty, despite best efforts, how is that typically managed?
Management really depends on the direction of the instability. For anterior instability, where the ball shifts forward, revision surgery might involve reducing any excessive humeral anteversion, that's an inward twist of the implant, and repairing or reconstructing the anterior capsule and the subscapularis muscle. For posterior subluxation, where the ball is shifting backwards, surgical options include procedures to tighten the posterior capsule and rotator cuff, or sometimes using posterior bone grafting to augment the back of the glenoid socket. However, the sources do highlight the quite high recurrence rate of instability after purely soft tissue revision procedures, particularly for posterior subluxation. And they suggest that converting the failing anatomic replacement to an RTSA might actually be a more reliable option in such challenging cases.
That makes sense if the soft tissues just can't provide the necessary stability. Changing the fundamental biomechanics with a reverse prosthesis could be the answer. What about fractures that occur around the prosthesis after surgery, these paraprosthetic humeral fractures? They sound serious.
They are another serious complication, yes, and their management can be very challenging indeed. The sources discuss various classification systems used to describe these fractures, which are important for guiding treatment decisions. The Campbell classification is based on the anatomic location of the fracture relative to the humerus itself, involving the tuberosities, where the cuff attaches, the metaphysis near the joint, or the proximal, mid, or distal diaphysis, the shaft of the bone. The Whirling classification categorizes fractures based on their location relative to the stem of the implant. Type A involves the tuberosities, Type B is at the level of the stem itself, and Type C is distal to the implant tip. Type B is further subdivided based on the fracture pattern and whether the implant itself remains stable, B1 spiral, B2 oblique near the tip, B3 unstable implant.
So the exact location of the fracture and whether the existing implant is still stable or has loosened are critical pieces of information for planning.
Absolutely. Assessment involves a comprehensive set of X-rays in multiple views, including full-length humerus views, to fully delineate the fracture pattern, assess implant stability, evaluate the remaining bone stock, and identify any pre-existing deformities. Metal suppression CT scans are particularly valuable here. They provide detailed 3D information on bone stock, definitively assess implant stability, clarify complex fracture patterns, and can even help evaluate glenoid version and cuff integrity, which might influence the choice of revision implant. Axial CT images can also help surgeons plan the trajectory of screws angled specifically to pass around the implant stem without hitting it during fixation.
And the management of these per-prosthetic fractures, what are the typical approaches?
Management is highly dependent on the fracture location and, crucially, the stability of the existing prosthesis. Metaphyseal or diaphyseal fractures occurring further down the bone shaft are often managed by revising to a longer humeral stem that extends well past the fracture site, ideally by at least 2 or 3 cortical diameters combined with supplemental fixation. This might include circlish wires or strong surgical tape or sutures wrapped around the bone, or sometimes plates and screws. Tuberosity fractures occurring closer to the joint where the rotator cuff attaches are typically managed with robust transosseous suture fixation, passing strong sutures through bone tunnels, sometimes augmented with screws, to securely reattach the rotator cuff tendons. Now, if stable fixation of the fracture fragments cannot be achieved with these methods, then converting to a dedicated fracture stem, a revision stem, or even a reverse shoulder arthroplasty might be necessary to bypass the fractured area and achieve stability.
What do studies show about the outcomes of surgically fixing these difficult fractures?
A systematic review by Morcus and colleagues looked at patients who underwent open reduction and internal fixation, or ORIF, for these fractures. They reported a high rate of fracture union, over 93%. Overall fracture healing was reported around 75.7% at an average of 5.5 months post-surgery. Patient satisfaction was reported at 72%. However, it's important to be aware of potential complications, which can include hardware irritation requiring later removal, temporary nerve palsies, infection, failure of the fixation construct itself, and unfortunately non-union where the fracture simply fails to heal. Contraindications to operative fixation generally include significant medical comorbidities that make surgery too risky for the patient, or the presence of an active infection around the joint.
Finally, in terms of major complications, let's look at loosening of the glenoid component, the socket side, after arthroplasty. This is known to be a particular problem with traditional TSA, isn't it?
Yes, glenoid component loosening is in fact the single most common reason for revision surgery in conventional anatomic total shoulder replacement. It's often attributed to what's called the rocking horse phenomenon. This describes eccentric loading on the relatively shallow polyethylene socket, causing repetitive micromotion at the interface between the component and the bone cement used to fix it. This eventually leads to loosening and associated bone loss behind the component. This loosening is frequently associated with the development of radiolucent lines, those gaps visible on X-rays around the component. These lines can sometimes appear quite early after surgery, reported in up to 96% of cases in some series, although not all lines signify clinical failure. The sources also note that the use of newer, highly cross-linked polyethylene, or XOPE, in the glenoid component has been associated with a significant reduction in the need for revision surgery due to loosening compared to older polyethylene materials.
So improved materials are definitely helping on that front. What about glenoid loosening and reverse total shoulder arthroplasty? Does that happen too?
Glenoid loosening also occurs in RTSA, although generally less frequently than with the conventional polyethylene glenoid in TSA. Prevalence rates are reported somewhere between 1.7% and 3.5%. In RTSA, the glenosphere that's the ball component fixed to the scapula is subject to both compressive and shear forces during movement. Excessive shear forces can be a major contributor to destabilization and eventual loosening of the glenoid base plate, which is the component directly fixed to the scapula bone. So loosening in RTSA typically occurs at the interface between that base plate and the underlying scapula bone.
How is glenoid loosening managed when it occurs in an RTSA?
Management often begins conservatively if symptoms are mild, and the loosening appears stable on imaging, perhaps activity modification or pain relief. If symptoms persist or the component becomes clearly unstable, surgical options usually involve revision surgery. This might involve revising just the glenosphere component, or more commonly, revising the entire base plate construct. Converting the reverse arthroplasty to a hemiarthroplasty, which means removing all the glenoid components and just leaving a humeral head component articulating against the native glenoid bone, is generally considered a last-ditch salvage option. Similar to resection arthroplasty for infection, it significantly compromises function but might be necessary in very difficult situations.
That provides a really comprehensive picture of the complexities and potential pitfalls involved in revision surgery and managing arthroplasty complications. It certainly highlights just how challenging these situations can be for both the surgeon and the patient. Let's now look forward a bit. How is technology influencing shoulder arthroplasty, and maybe touch briefly on outcomes in some specific patient populations?
Okay. Technology is definitely playing an increasing role, particularly in the realms of preoperative planning and intraoperative execution. As we've already touched upon, advanced imaging is absolutely critical. CT scans provide that detailed 3D information about the patient's bone stock, their glenoid version, inclination far more accurate than traditional 2D measurements for planning complex arthroplasty. And MRI remains essential for evaluating the soft tissues like cartilage and assessing the rotator cuff for tears and fatty infiltration, which informs the choice between anatomic and reverse replacement.
And how is that advanced imaging information then translated into the operating room to help the surgeon?
Well, it forms the basis for technologies like computer-assisted navigation and patient-specific instrumentation, or PSI. Both of these systems are primarily designed to improve the accuracy of placing the glenoid component, which, as we know from the loosening discussion, is absolutely crucial for long-term function and implant survival. PSI uses the preoperative CT scans to create custom surgical guides that fit precisely onto the patient's bone during the procedure. These guides help the surgeon achieve very precise bone cuts and positioning for the glenoid implant. Navigation systems, on the other hand, synchronize the patient's anatomy with their preoperative CT scan in real time during the surgery. This provides the surgeon with dynamic feedback on component positioning and alignment as they are performing the procedure. Systems like Blueprint or Exactech GPS are examples.
And does using these technologies definitively lead to better long-term outcomes for patients? Is the extra tech worth it?
That's the key question, isn't it? Numerous studies cited in the sources consistently show that both navigation and PSI significantly improve the accuracy of glenoid component positioning compared to traditional freehand techniques. That part seems clear. However, it's important to note that the sources highlight a current limitation. There is still limited direct, high-level evidence definitively linking this improved surgical accuracy specifically to improved prosthesis survivorship or better long-term patient functional outcomes. While the logical assumption is that more accurate placement should lead to better results in the long run, robust long-term clinical data making that direct connection is still developing.
What about robotic-assisted surgery? We hear a lot about it for hips and knees. Is that as prevalent in shoulder replacement yet?
Robotic systems are certainly being used increasingly in hip and knee arthroplasty. They're used to enhance the accuracy of bone cuts and implant alignment. And they offer potential benefits like reduced radiation exposure compared to some navigation techniques, and potentially less soft tissue damage, which might translate into less bleeding and maybe less post-operative pain. These systems use preoperative advanced imaging to create detailed 3D plans that the robot then assists the surgeon in executing with high precision. However, the sources explicitly state that there has been significantly less development and clinical data specifically for shoulder arthroplasty compared to hip and knee robotics. While systems are emerging for the shoulder, the widespread adoption and the body of supporting evidence haven't quite caught up yet.
So, still an evolving area for the shoulder specifically. Let's turn now to some specific surgical techniques and considerations highlighted in the sources, particularly managing the subscapularis muscle during arthroplasty. This seems to be quite a recurring challenge.
It is a significant challenge, yes. The sources report a rather worrying failure rate for various subscapularis tendon takedown and reattachment techniques used during shoulder replacement surgery, sometimes as high as 40%. That means the tendon doesn't heal back properly in a large number of cases.
Why does the subscapularis need to be addressed or disturbed during shoulder replacement surgery in the first place?
Well, in many traditional surgical approaches to expose the glenohumeral joint adequately for replacement, the subscapularis tendon, being at the front, needs to be released from its attachment point on the humerus to allow the surgeon access. It then needs to be repaired securely at the end of the procedure to restore its function. Different techniques exist for this release and subsequent repair, ranging from simply splitting the tendon fibers longitudinally to detaching it completely from the bone, sometimes with a small piece of bone attached, called a lesser tuberosity osteotomy. The sources describe a mini-open approach described by Savoy and colleagues, where only the lower portion, perhaps 30–50% of the subscapularis tendon, is split or detached, preserving the upper part. This technique is particularly used for humeral head replacement or resurfacing procedures where less exposure might be needed. Detailed surgical steps are often provided in technique guides, involving a standard deltopectoral surgical approach, managing the biceps tendon, carefully splitting the lower part of the subscapularis, and lifting the tendon away from the bone from underneath, superius diali.
And what about the technical aspects of actually repairing that tendon, whether it's in a primary setting or during a revision? What makes a repair strong and likely to heal?
The sources delve into various techniques aimed at achieving a really robust repair, learning from biomechanical studies. These studies show that augmenting a simple side-to-side suture repair with sutures passed directly through tunnels drilled in the bone, what we call transosseous sutures, can make the construct significantly stronger. Double-row anchor-based repairs, using multiple suture anchors placed on the bone and passing sutures across the tendon footprint, have generally shown higher load-to-failure strength compared to single-row repairs. Particularly in the context of stemless humeral implants, where there's more bone available for anchors. Different double-row configurations, such as backpack versus knotless techniques, have been shown to have similar biomechanical properties in some studies. The literature suggests that repair techniques that provide good compression and tension across the tendon-bone interface may be biomechanically optimal for healing. Interestingly, passing sutures around the humeral stem, if a stemmed implant is used, can provide biomechanical benefits that are equivalent to a stem-based peel technique, where the tendon is peeled off the stem itself. Furthermore, one study showed that using a suture tape repair, a flat, broad suture secured with a specific type of knot called a racking hitch, demonstrated significantly higher load to failure compared to traditional suture repairs.
So a huge amount of detailed biomechanical research is constantly refining how best to reattach that absolutely critical tendon. What about the long head of the biceps tendon, the LHB? It also runs right through the shoulder joint and can be a source of pain. How is that typically managed?
Yes, the long head of the biceps tendon is very commonly addressed during shoulder arthroplasty. Surgical options generally include simply cutting the tendon and letting it retract, called a tenotomy, or cutting it and then reattaching it to the humerus further down outside the joint, which is called a tenodesis. It can also sometimes be left untreated if it appears healthy and stable. If the LHB is left in place, however, issues like tethering, where it gets caught, or becoming incarcerated or trapped between the implant components and the bone, can potentially cause persistent postoperative stiffness or pain. The sources note that if stiffness or impingement related to the LHB persists after arthroplasty despite good rehabilitation, an arthroscopic procedure to address the biceps, perhaps perform a tenotomy or tenodesis, or release surrounding scar tissue might be necessary later on.
Let's discuss tendon transfers now. These sound like a much more complex salvage option, typically used when the rotator cuff tissue is irreparable and just cannot be re-repaired directly.
Tendon transfers are indeed a complex salvage surgical option. They're generally reserved for specific cases of irreparable rotator cuff tears. For example, massive tears of the subscapularis that are either due to trauma or long-standing degeneration, where the tendon is simply too retracted or the muscle tissue too degenerated to be repaired directly back to the bone.
What are the core principles that guide the decision to perform a tendon transfer? What makes for a suitable transfer?
The sources outline several key principles for a successful tendon transfer. Firstly, the muscle being transferred must be considered expendable, meaning its removal won't significantly compromise the function of the donor site. Secondly, it should ideally have similar excursion, that's the distance it can contract and relax, and tension characteristics to the muscle it's replacing. Thirdly, its line of pull after transfer should ideally mimic the primary function of the deficient muscle it's intended to replace. And finally, it should primarily aim to restore one specific function, not try to replace multiple complex actions.
And who would generally not be a good candidate for a tendon transfer? When is it contraindicated?
Right. Contraindications for tendon transfer typically include the presence of concomitant massive tears in other parts of the rotator cuff, like the posterior superior cuff. Also, static anterior subluxation or dislocation of the joint, where the ball is already chronically shifted significantly forward and unstable. Any significant nerve injury or brachial plexopathy that affects the function of the potential donor muscle would also rule it out. And importantly, the presence of significant glenohumeral arthritis. In patients with arthritis, alternative procedures like reverse shoulder arthroplasty or even shoulder arthrodesis, surgically fusing the joint, might be more appropriate choices.
Which muscles are typically transferred to address, say, a deficient subscapularis tendon?
The pectoralis major muscle, the large chest muscle, is the most commonly transferred muscle to address insufficiency of the subscapularis. It's described as helping to partially restore the anterior force couple and providing an internal rotation and centering force on the humeral head. helping to prevent anterior escape. Other muscles that can sometimes be considered for transfer include the pectoralis minor, a smaller chest muscle, or the latissimus dorsi, the large back muscle, which is often transferred along with the teres major muscle to reconstruct a deficient subscapularis in certain situations. These procedures can be performed with traditional open surgical techniques or sometimes assisted arthroscopically.
Are there specific technical considerations mentioned for something like a pectoralis major transfer?
The pectoralis major transfer, a technique originally described by Worth and Rockwood, is often considered a salvage procedure, particularly for failed previous subscapularis repairs. For the latissimus dorsi transfer, which can also reconstruct a deficient subscapularis, the surgical approach is typically deltopectoral, or sometimes through an axillary incision. The sources describe carefully dissecting the latissimus dorsi and teres major muscles near the axillary crease, meticulously identifying and protecting the neurovascular structures, particularly the axillary nerve, which runs nearby, and then transferring the muscle tendon unit through a specific pathway, often on the posterior aspect of the humerus, typically passing beneath the axillary nerve to reach the anterior insertion site.
And where is the transferred muscle tendon actually reattached on the humerus?
The exact fixation site is somewhat debated in the literature, but it's typically reattached to the humerus near the original insertion points of the subscapularis, or perhaps slightly more laterally, near the insertion of the teres minor or pectoralis major. It is sometimes recommended to fix the transferred tendon with the arm positioned in some degree of external rotation and perhaps slight hyperextension. Although the sources suggest that if the muscle is adequately released during dissection, its inherent excursion should allow successful fixation in various arm positions. Post-operatively, immobilization, often in external rotation or perhaps a neutral position depending on the transfer, is recommended for about 6 to 8 weeks to allow the transferred tendon to heal securely into the bone before starting active motion.
These sound like very involved and complex procedures with many variables. What does the literature actually say about the long-term outcomes or success rates of these tendon transfers? Are they reliable?
Well, the sources generally note a relative lack of robust, long-term outcome data for many of these complex transfers. Caution is often advised regarding their use, especially as primary procedures, and their specific role, particularly in combination with or perhaps preceding a reverse shoulder arthroplasty, is described as still evolving as surgeons gain more experience and more long-term data becomes available. They are definitely salvage procedures for difficult problems.
Can arthroscopy keyhole surgery be performed after a patient has already had a shoulder arthroplasty, a replacement?
Yes, absolutely. Arthroscopy can be used after shoulder arthroplasty in specific situations. It can be very helpful to evaluate the joint and potentially address persistent pain or range of motion limitations that aren't clearly related to component loosening, malposition, or underlying infection. For instance, if stiffness or arthrofibrosis persists despite a rigorous rehabilitation program and isn't due to mechanical issues with the implant itself, then an arthroscopic contracture release or lysis of adhesions, which means carefully cutting through restrictive scar tissue, might be indicated to improve motion. Arthroscopy can also be used to assess and potentially address issues like biceps tendon tethering or impingement post-arthroplasty. While arthroscopy can certainly be used to assess potentially loose components, actually removing cement or a firmly fixed prosthesis component would typically require a more extensive open procedure. It's also important to exercise caution with suture anchor placement if performing concurrent procedures arthroscopically near a prosthesis to avoid damaging the implant surfaces or the underlying bone cement mantle.
Okay, let's wrap up this deep dive by looking specifically at outcomes and considerations for shoulder arthroplasty in some distinct patient populations that the sources highlight. Firstly, how does performing a traditional total shoulder arthroplasty, an anatomic TSA, in patients who also have a rotator cuff tear affect the results?
Right. The sources estimate that about 5% of patients undergoing a primary anatomic TSA actually require a concomitant repair of a torn rotator cuff tendon during the same surgery because a tear is found intraoperatively. Now, while significant improvements in range of motion and pain are certainly possible for these patients, studies consistently show that the rate of postoperative instability is increased, particularly when dealing with medium or large cuff tears at the time of TSA. This strongly suggests that the cuff repair performed at the same time as the TSA often doesn't heal successfully in this population. And indeed, about half of these patients may eventually require revision surgery, often to a reverse replacement.
So, trying to fix the cuff at the same time as putting in a traditional replacement doesn't necessarily guarantee a stable, healed cuff in the long run, especially with bigger tears.
That seems to be the key finding, yes. particularly for larger tears or perhaps in older patients with potentially poorer tissue quality. Studies, including those referenced by Erickson, Schiffman, and Schoch in the source material, suggest that outcomes in patients needing cuff repair at the time of TSA are either slightly inferior or perhaps not significantly different compared to outcomes in patients undergoing TSA who have a completely intact rotator cuff to begin with. The analysis suggests that for small supraspinatus tears, especially in younger patients with good tissue, repairing the cuff during TSA might yield outcomes comparable to those with an intact cuff. However, for larger tears or in older patients, a reverse total shoulder arthroplasty RTSA, which remember is less reliant on a functional rotator cuff for stability and function, might offer more reliable and durable results.
Speaking of RTSA then, what are the outcomes like in younger patients, say those under the age of 65? There's historically been some caution about using RTSA in this more active group, often due to concerns about implant longevity.
Historically, yes, there was significant caution surrounding implant survival, long-term outcomes of RTSA in younger, potentially higher demand patients. Surgeons worried the implants wouldn't last. However, more recent studies are painting a much more promising picture. Studies by Van Colen et al. And Honish et al., for instance, which are cited, report significant improvements in both range of motion and patient-reported outcomes, PROs, in younger RTSA patients, comparable to older groups. They note acceptable complication rates, perhaps around 18 to 18.6%, which is in line with complex shoulder surgery, and surprisingly good implant survival rates reported, even out to 10 years in one study, around 88% survival.
So the general perception around using RTSA in younger patients might be shifting based on this newer data?
The data is certainly becoming more encouraging, yes. Some studies even suggest there's no clinically relevant difference in outcomes compared to patients over 65 undergoing RTSA. However, it is crucial to acknowledge a general trend that's observed across all types of shoulder arthroplasty, whether it's TSA, RTSA, or hemiarthroplasty. And that's a trend indicating higher revision rates in younger patients, regardless of the implant type used. One large review calculated approximately a 3% decrease in revision risk for every year of increased patient age at the time of surgery. So being younger inherently carries a slightly higher risk of needing revision down the line. This isn't unique to RTSA, but it is an important factor to consider when discussing any arthroplasty option with younger individuals. It's possible that modern implant design features, like lateralized glenoids and modified neck shaft angles in RTSA, may be contributing to improved survival across all age groups, but we really need more long-term data to definitively confirm this trend.
How does RTSA fare specifically in patients with rheumatoid arthritis, that RA? That inflammatory condition must present unique challenges.
Yes. RTSA was initially developed primarily for cuff tear arthropathy, where a massive rotator cuff tear leads to secondary arthritis. However, its indications have definitely expanded over time to include inflammatory arthritis conditions like rheumatoid arthritis. Some earlier studies did occasionally report poorer outcomes and potentially higher complication rates in RA patients compared to other causes of shoulder problems needing RTSA. They cited issues such as increased risk of intraoperative fractures due to poor bone quality, higher rates of glenoid loosening, and perhaps increased infection risks in this often immunosuppressed patient population.
And what's the current thinking based on more recent evidence for RA patients?
Well, a recent systematic review suggests that short to mid-term outcomes for RTSA in RA patients are actually quite similar to those seen in patients with cuff tear arthropathy. And crucially, with no significantly higher complication rates compared to other indications when performed carefully. Studies by Mangold et al. And others indicate that RSA provides excellent pain relief and significant functional improvement with minimal complications in selected RA patients. They report high revision-free survivorship rates, sometimes over 96–97%, at follow-up periods ranging from 2 to 7 years.
That's a very positive shift in understanding outcomes for what must be a challenging patient group. Bone loss is also quite common in RA, particularly on the glenoid socket side. How is that managed in RTSA for RA patients?
Yes, severe glenoid bone loss is frequently encountered in RA patients. It often necessitates bone grafting procedures in a significant percentage of cases, reported between 24% and 45% in some surgical series, to provide a stable platform for the glenoid baseplate. The sources also mentioned the potential use of patient-matched or custom glenoid implants as an emerging option for managing severe glenoid dysplasia or malformation, which can sometimes be seen in long-standing RA patients.
Let's look now at the outcomes for arthroplasty when a patient has already undergone previous shoulder surgery like a rotator cuff repair, RCR, or maybe even something more complex like a superior capsular reconstruction, SCR. Does having had prior surgery significantly impact the outcome of a subsequent arthroplasty?
The sources generally indicate that outcomes for total shoulder arthroplasty in particular are significantly inferior in patients who have previously undergone procedures like rotator cuff repairs or even just extensive debridement compared to those who are having RTSA as their first surgical intervention on that shoulder.
And specifically comparing the outcomes of RTSA after a failed SCR versus a failed RCR, is there a discernible difference based on which prior surgery failed?
The evidence presented in the sources on this specific comparison is actually somewhat mixed. Some studies cited suggest lower postoperative passive and active range of motion improvement after RTSA if the patient had a previously failed SCR, compared to control groups, or perhaps those with only failed RCR. However, other studies found that outcomes regarding pain relief, overall range of motion improvement, and stability after RTSA were similar, irrespective of whether the patient had undergone a prior RCR or SCR. One large study by Marighi et al. Did show that while patients with a prior RCR did experience significant improvements in patient-reported outcomes and range of motion after subsequent RTSA, these improvements were generally less pronounced than those seen in control groups who hadn't had prior surgery. Although, importantly, the complication and reoperation rates were similar between the groups. So the takeaway is that while RTSA can still provide substantial benefit to patients who have had previous failed surgery, the degree of improvement might not be quite as great as what can be achieved in those undergoing primary arthroplasty without prior surgical scarring and tissue disruption.
Finally, let's compare the two main modern approaches head-to-head. The traditional approach, anatomic TSA versus reverse TSA, specifically for the common situation of primary osteoarthritis in a patient who still has a healthy, intact rotator cuff. When would you choose one over the other in that scenario?
Right, this is a really key decision point in modern shoulder arthroplasty. For an appropriately selected patient with primary osteoarthritis and a documented intact functional rotator cuff, anatomic shoulder arthroplasty, ATSA, remains widely considered the gold standard treatment. The rationale is that it replaces the diseased joint surfaces while aiming to reestablish the patient's native anatomy as closely as possible. It aims to restore painless function by preserving the original biomechanics, which, as we've discussed, rely heavily on that intact rotator cuff for stability and controlled motion. Its long-term success, however, is highly contingent on careful patient selection. This includes having minimal pre-existing cuff disease, healthy underlying bone quality, few significant medical comorbidities, and crucially, the patient's ability and motivation to comply with what can be a potentially rigorous rehabilitation program post-operatively. Anatomic TSA also retains theoretical advantages in certain specific subgroups, such as patients with neurological conditions like Parkinson's disease or a history of stroke, where preserving the original cuff function and proprioception might be particularly beneficial.
And when would a reverse TSA be considered for someone who doesn't actually have a significant cuff tear but just has primary OA?
Reverse TSA, or RTSA, is becoming increasingly accepted and utilized for this indication as well. Partly, this is due to its perceived technical ease compared to managing complex glenoid deformities or bone loss during primary anatomic TSA. This is combined with ongoing implant refinements and a growing body of favorable outcomes data for RTSA across various indications. Essentially, the threshold for using RTSA, even in patients with relatively intact cuffs, has decreased over time, particularly in older patients where longevity concerns might be slightly less paramount.
Are there direct comparative studies that have looked specifically at ATSA versus RTSA for this group primary OA with an intact cuff?
There are relatively few high-quality head-to-head randomized controlled trials directly comparing the two for this specific indication. However, some systematic reviews and large cohort studies do provide valuable insight. A systematic review by Kim et al. Suggested that overall range of motion might be slightly better with ATSA, particularly external rotation. However, overall functional scores were generally similar between the two procedures at midterm follow-up. They found that ATSA had higher reported rates of glenoid loosening over time, whereas RTSA had higher rates of scapular notching, where the humeral component impinges on the scapular neck, although this notching is often asymptomatic. Overall revision rates were reported as similar between the two approaches in that review. Another important study by Wright et al., specifically looking at patients over the age of 70, noted similar complication and reoperation rates for both ATSA and RTSA. But importantly, they found that 6.9% of the ATSA procedures performed in this elderly group ultimately required revision surgery later on. And the primary reason for revision was subsequent failure of the rotator cuff, often a posterior cuff tear developing years after the initial TSA, necessitating conversion to an RTSA. And a study by Haratinian et al., looking at somewhat younger patients with OA and intact cuffs, found that while preoperative range of motion and functional scores were actually higher in the group selected for ATSA,
The postoperative outcomes achieved were ultimately similar between the ATSA or RTSA groups. This study particularly highlighted the relatively high rate of rotator cuff insufficiency observed at midterm follow-up after ATSA as a significant factor influencing the decision-making process, especially given the similar overall outcomes achieved compared to RTSA in their population.
So, even if the cush is perfectly intact at the time of the initial anatomic TSA, there's a non-negligible risk that it might fail later on down the line, potentially leading to another major surgery to convert to an RTSA anyway. That seems like a major consideration in the decision.
It is a very significant consideration, yes, especially when thinking about long-term planning and patient counseling. The sources tend to conclude that for an appropriately selected patient, ATSA still remains the gold standard for reconstructing native biomechanics and achieving potentially excellent motion and reliable pain relief in advanced glenohumeral arthrosis, regardless of age, if the conditions are right. They point to similar complication and reoperation rates compared to RTSA in the elderly population specifically, and cite high 5-year implant survival rates, often over 98% for modern ATSA in this older group. However, they crucially stress again and again that the overall long-term success of ATSA is highly dependent on the sustained function of that rotator cuff over time, as well as surgeon skill, underlying bone quality, meticulous soft tissue management during surgery, and patient compliance with rehab. The potential for later rotator cuff failure after ATSA, which might necessitate a potentially complex conversion to RTSA, is a key factor that needs to be weighed carefully against the initial biomechanical advantages of preserving native anatomy with ATSA, particularly given the increasingly positive and reliable outcomes being seen with modern RTSA designs across a broader range of indications.
Prof. Imam, this has been a truly fascinating and, well, deep dive, hasn't it? Taking us right from the fundamental anatomy and biomechanics of the shoulder all the way through the intricacies of primary and revision surgery, the potential complications, and the outcomes in various challenging scenarios.
It really underscores the significant complexity involved in navigating shoulder health issues, particularly when initial treatments aren't successful or when dealing with advanced arthritis or indeed failed previous surgery. Understanding that delicate interplay of biomechanics, weighing the numerous treatment options available, carefully considering patient-specific factors like age and activity level, and being acutely aware of the potential complications of the nuances of revision surgery are all absolutely paramount.
Yes, and as revealed in these detailed sources we've explored, the choice of treatment is rarely straightforward, is it? It almost always involves carefully balancing the potential benefits and risks of different approaches, especially when dealing with active or younger patients where the demands on the joint are higher and the potential lifespan of any implant is a really significant consideration.
Absolutely. And the ongoing advancements in technology, things like improved imaging, navigation systems, emerging robotic platforms, and the continued exploration of biologic augmentation strategies, they definitely hold promise for improving outcomes in the future. However, as the current literature clearly highlights, the field is still characterized by significant complexity and sometimes frustrating variability in results.
If you found this deep dive valuable today and perhaps gained some new insights into the challenging world of shoulder health, please do take a moment to rate and share it so others can also benefit from exploring complex topics like this one. And just as a final thought to leave you with, as we've explored the often unpredictable outcomes in complex shoulder surgery, particularly revision procedures, what does this literature on complications and variable results perhaps teach us about the broader professional challenge? The challenge of balancing high expectations, whether they're from patients, clients, or stakeholders, with the inherent uncertainties and complexities that exist in any complex professional endeavor.